We take the next speaker, Stephen Morbach. Shego has partly already recognized him. Stephen is from Germany, but his key interest, beside having his own clinic, is also that he's been keen on data collection and looking at what is a short and long-term prognosis for patients with diabetic foot ulcers, and also how to actually organize a team. So, Stephen, the floor is yours.
Thank you, Jan. Thank you, Carol. And thanks to organizers for having me again here at the EWMA meeting at the Diabetic Foot Day to speak initially on our attempt to harmonize a little bit the foot care we're doing for the diabetic foot in Germany by introducing so-called certified diabetic foot clinics. I'm going to tell you the story and the outcomes that we have so far with this project. The background of the whole thing, as in most cases, and Carol told you the global aspect of this, was that as a consequence of the St. Vincent Declaration in the late 1980s, we got the first information about amputation in Germany based on a 5-year population-based study in Leverkusen, in the central part of Germany, that gave us, by calculating those data on the German population, an estimation of around 30,000 amputations per year, of which more than 70% were performed in diabetics. This study was continued, and in the late 1990s we saw that there was hardly any changes year by year. From political side and from people who didn't see the problem as that important, there was always said, okay, this is one region extrapolated to the whole country. So it became more interesting when in 2004 we got official hospital demission data from a survey which was done in more than 90% of all hospitals in Germany which perform amputations. And now it was not an estimation based on one population-based study, but real data from hospital demissions. And the numbers were quite equal, around 70% amputations performed in diabetes, and a complete number of even more than 40,000 amputations. Numbers like that led to the attempt in Germany that politics introduced a nationwide disease management program for diabetes in 2003 with the attempt to improve quality of care for people with diabetes in general and diabetic foot in special. And these programs had, by regulations, defined contents and timeframes for the treatment of diabetic and its comorbidities, as well as defining clearly the interfaces among the different levels of care for those patients. In the concept of the diabetic foot, that meant, and this was in the regulations of these disease management programs, that providers were obliged to refer their high-risk patients, but also their ulcerated patients and Charcot patients at predefined interfaces to so-called specialized foot clinics. So for the first time, there was the term of the specialized diabetic foot clinic in an official political regulation paper. And at that point, people from the German working group on diabetic foot felt responsible to fill that term with sense, to make something out of this term. And therefore, we defined by that time standards for quality of those specialized diabetic foot clinics according to the criteria of the diabetic foot working group of the German Diabetes Association. The background of this was that already in 1992, this working group was founded, and since then, every year performs a 2-day working group meeting. And it's the largest of all the working groups in the German Diabetes Association, with momentarily more than 500 members. And the primary goal, and it was in the regulations of this working group, was to implement the so-called Oppenheim Declaration for amputation avoidance in Germany. The Oppenheim Declaration, in fact, was the birth document of the working group, formulated in the year 1993 by a small group of diabetologists, surgeons, and other people working in the area of the diabetic foot. And the 4 major points of this Oppenheim document were that there had to be a clear diagnosis in every diabetic foot using aspects of neurological and vascular aspects, but also that major amputation should never be a primary procedure for a diabetic foot disease, that every patient should be offered revascularization in the case of PAD being part of his problem, and that before any amputation, as well, a diabetologist as a vascular specialist should have been in the process of discussing if the patient had no other option than major amputation. That was the 4 points, and we felt with the disease management programs now the time had come to set up structures to realize them. This was in the typical German manner really strictly regulated the basic aspects that we defined as essential criteria to certify a center as a specialized foot clinic. And as you can see, and I'm going closely in some of the points, there were aspects of structural quality, but there were also 3 specific points that we defined for controlling the work of those centers. On the one hand, by asking them and forcing them to prove interdisciplinary care by having cooperation documents with their collaborators, but also by asking them to have annual audits. That means inviting people to see their service and go to other places and document those visits as well. And the third part was that as a part of the certification process, every center had to collect 30 consecutive diabetic foot cases from their centers regarding outcomes and present them at the annual conferences. Just shortly, I'm going to the structural quality. All the members of the team had to be named by their qualification and their role in the service, and also they had to be organized a 24-hour emergency service for diabetic foot patients. That must not have been if it was a private practice, in the practice, but then the patients had to have a chance to call a nearby hospital with the same qualification. As I told you, one of the major points for us was that we're not only speaking about collaboration, but that the interdisciplinary cooperation had to be proven by contract. That means that written agreements of cooperation between surgeons, vascular surgeons, diabetologists, podiatrists, and other parties working in the area had to be sent for certification, and at least 5 individual contracts had to be given to receive the certificate. I already spoke about the active and passive audit. That meant that the staff members from each of the centers had to visit each other once every 3 years for recertification for 1 day, and these audits had to be documented in a standardized form, and also by request be presented at the annual meetings, speaking about the special things you observed at the center that you visited. And the third point I already told you was that also a treatment quality had to be documented. That means that each center had to investigate 30 consecutive patients for each certification period with foot lesions, with baseline characteristics in a defined form, and 6-month outcomes regarding healing, amputation, interventions, and also by demand had to demonstrate those data at the annual meeting of the working group. This project and this structure for certifying foot clinics had for the first time been presented at the DFSG meeting in Elsinore in Denmark in 2006. And since then, we have a relatively constant number of between 200 and 300 certified centers throughout Germany, standing February this year. And as I told you, the certification has to be renewed with all the requirements I just told you every 3 years. This is the numbers of centers on outpatient basis and hospitals, and as you can see, while the numbers of outpatient foot clinics which are certified are steadily increasing a little bit, the numbers of hospitals are relatively stable at around 80, which means at a population of 80 million, 1 hospital on average per 1 million inhabitants in Germany at the moment, which has this certificate. We have a website of the German working group, and you see the map of Germany with all the different counties. And if you click on the counties, you receive a list of the centers which are approved in that region. And for each center, if you click on the center, you have the contact numbers for the patients or for GPs who want to refer a patient, where they can see the working hours, who have an email contact or telephone contact, and also can see how long the approval is still valid for a certain center. In a combined analysis of the first 3 years of this certification process, a complete number of 13,000 patients had been followed for 6 months. And as you can see, the primary healing rate was slightly below 60% for 6 months, around 20% minor amputations, below 4%, over 200 centers, major amputations, and a death rate at 6 months of 5%. There's newer data just in publication in the Journal of Wound Medicine now. And if you look a little more specifically at the numbers, you can see that as well, vascular interventions and minor amputations remained relatively stable over the years. Also the hospitalization rate of those patients. But interestingly, over the years, the major amputations, which were relatively low already with 4%, get even lower in the area between 2 and 3% now in the centers. And also interestingly, the death rates at 6 months show a clear trend for reduction over the years between 2006 and 2011. And this is in concordance with a study that we just published from the data of a nationwide acting health insurance, where you can see in comparing the survival of people after major amputation that in the German cohort now, people with diabetes seem to have a better prognosis for the at least first 2.5 years after amputation than non-diabetics. So the effect is seems not only to be valuable for saving limbs, but also for saving lives by having a more strict and more structured approach to treating those people. Another country who is doing a very structured approach to diabetic foot clinics is Belgium, and they made an estimate how many people do you need to control to have a representative statement on the service you give. And what they are doing, as I told you, we are doing 30 patients for each certification period. They are doing 52 patients for every year, and you can see between 30 and 50 patients the confidence limits are relatively comparable. That means that the comments that you can give on the base of 30 consecutive patients or 50 consecutive patients from a center gives a good statement on this, the quality of the service which is given in general. Also, there's nothing perfect in the diabetic foot world, and also our project, as nice as it looks with the patient and the lesion available, the defined foot clinic now, the guideline that we wrote for it to the way of healing. Still, the problem is not every patient reaches this service, and an analysis from the North Rhine area, where you see the goals for the disease management programs like HbA1c measurement, the targets reached, or referral to eye specialists, the diabetic foot clinic referral still just reached 1/3 of the people. That means 2/3 of the people still get lost somewhere in between, and only 1/3 gets a service in such a structure. And this is also in accordance to a study that has been done last year or published last year from Eastern Germany, where you can see that a hospital working according to these regulations with the certified foot clinic had a 4.7 major amputation rate, and a nearby hospital which no interdisciplinary care, where everybody worked independent from each other, had a major amputation rate of more than 20%. So different success rates just in the same area, depending on your structures. That means primary care, the collaboration with the GPs is the crucial point to reach as many possible patients with a structure like that. And therefore, for the area that I come from, that I work in the Westphalian area, we made an additional contract with the health insurances and said, we now have the certified outpatient clinics, the certified hospitals. Please let us make contracts within the disease management program with the family physicians, also with the podiatrists, community care, and the shoemakers. And this started in our area with 7 centers in the first years, including mine. That was the year 2007. Then 2008, it went up to 24 certified foot clinics and almost 500 affiliated primary physicians in the region. This is a region covering something like 8 million inhabitants. And this is the standings from 2012, with now 40 certified clinics and 600 affiliated primary physicians. The number of certified clinics is staying stable at a number of around 40, but the numbers of affiliated primary care physicians is still going up. What's missing there at the moment is the outcome data on the patients. But you can see here the German map, and in light green, that was the region that I just showed you. In dark green, you can see the North Rhine area, including cities like Cologne and Düsseldorf. You can see up in the north Hamburg, and you can see Berlin. And from those three networks, we have outcome data as well. And I'm showing you shortly an analysis done in 2007 from those regions. And what you could see is that the major amputation risk for patients treated in network was around 2%, the same number like in the national approach to the certified clinics, compared to 8% in patients who were not treated in network. And interestingly, the differences were angiography prior to major amputation, which was 100% in the network and only 55% in the patient treated in standard care. And also revascularization prior to MA was only 35% in the standard care and 80% in the network. So that's the difference you have to do to make the saving of the legs. Also, as I showed you before, there was an impact on mortality, seeing that the mortality rate at, I guess it was 1 year, went down from 25 to 18%. There's no published data at the moment, no officially published data on the amputation trends nationwide in Germany, but this is from a talk 2009 at the German Diabetes Association meeting from the largest health insurance, which covers around 60% of all diabetics in Germany, all insured people in Germany. And what you can see that from the year 2004 on, there's a rise in the upper curve, which is the minor amputation, and a fall in the major amputations, also as a reflection of the certified processes seem to have a certain impact on patient treatment. This can also be seen in the latest publication from the Leverkusen study that I showed you in the beginning. Between 1990 and 1998, I showed you there was no change in amputation rates, but going now over the whole period between 1990 and 2005, they could show a reduced incidence of major amputations also in this population-based study. But as you all know, the diabetic foot is a lifelong process. This is nothing that ends with just one episode. And therefore, from the Cologne, Berlin, and Hamburg network, you can see 35% had at least one recurrence in the year after healing their first lesion. This is in quite nice accordance with the data that Jan Appelquist already published in 1993, but also my own data published last year and data from Eurodial and other studies, which all lie at the one-year recurrence rate somewhere between 30 and 40%, which is, of course, much better than the natural history, which, without doing any intervention, studied by Ernst Schantelau and colleagues some years ago, but which is also below the things you can reach in a perfect world under study conditions, like you see in the green columns from studies also from Ernst Schantelau and the Larry Levery study on thermometry. If you go on to year 3, you go to around 60%. After 5 years, that was also Jan Appelquist's data on mine, you go to 70%. And if people live long enough, after 10 years, almost every one of them will have at least one new lesion. So we have data to confirm the request from David Armstrong and Joe Mills not to speak about any longer to speak about healing of the diabetic foot, but speaking about putting the diabetic foot into remission and probably keeping it there, using a new terminology and having a better statement basis in discussions, for example, with health insurance or politics. With that, I summarize my talk that a certification procedure, like we did it in Germany, is probably helping us to have comparable results in different settings and contributes to show a trend in amputation reduction in our country. In some regions, health insurance and politics have accepted this certification structure even for reimbursement contracts, and therefore there's extra money for doing good quality. And what we are trying now is to eliminate any white spots, blank spots, where we don't have those services, and also are in the process of building up a register with the data that we are collecting from those, and getting a more specific picture on what's really happening with the diabetic foot in Germany. With that, I thank you for your audience.